Hi dear students, today we start studying special part of radiology. Please note that today's lecture is important for you because today I will teach you dental radiologic methods. Subject of our today's lecture is dental radiology imaging techniques. Plan of our today's lecture is dental imaging general principles, dental x-ray methods, digital imaging, and radiological anatomy of the oral cavity. You know that each dentist in his practice approach different diagnostic methods every day and mainly in all cases, and the treatment is chosen based on the results of the diagnostic imaging. Because dental radiology and different diagnostic imaging are so important is dental practice. The rapid technological advancement of X-ray systems for dental practice requires a continuous update and justification of radiographic applications and guidelines. Dentists are challenged by the increasing complexity of systems and the multitude of diagnostic tasks. The use of X-rays as an integral part of clinical dentistry, with some form of radiographic examination necessary on the majority of patients. As a result, radiographs are often referred to the clinician's main diagnostic aid. The range of knowledge of dental radiography and radiology thus required can be divided into four main sections. First, basic physics and equipment, the production of X-rays, their properties and interactions which result in the formation of the radiographic image, radiation protection, the protection of patients and dental staff from the harmful effect of radiation, radiography, the techniques involved in producing the different radiographic images, and radiology, the interpretation of these radiographic images. All dental imaging methods we divide into main parts: intraoral methods and extraoral methods. We have four main types of intraoral radiography: periapical view, bite wing view, occlusal view, and full mouth series. We also have five main types of extraoral radiography. As you can see here, they are different types of tomography: temporomandibular joint view, maxillary sinus view, which are so important for maxillofacial radiology. Sometimes we use from contrast investigation. In radiology of dental disease, we name it cystoscopy. This investigation of salivary glands after contrasting of them. Okay. Recently, in dental practice, we use from different advanced technology. They are computer tomography and cone beam CT, magnetic resonance tomography, different types of digital imaging, for example, radiovisiography. Okay, first of all, I will say you about development of dental techniques. As you know, in 1895, Röntgen discovers X-rays, and in this year, first dental radiograph is taken. 1 year later, first intraoral radiograph taken, and after that, 1930, hot cathode X-ray tube invented, and 1905, bisecting technique developed, 1920, paralleling technique developed, and 1923 develops dental X-ray machine, and finally so important method, panoramic technique, developed in 1959. Okay. As you know, the image is produced by X-rays passing through an object and interacting with the photographic emulsion on a film. This interaction results in blackening of the film. The extent to which the emulsion is blackened depends on the number of X-rays reaching the film, which in turn depend on the density of the object. On X-ray, we can see three intensity of shadows. The white or radio opaque areas we name shadows, and the white and radio opaque shadows on X-ray film represents the various dense structures within the object which have total stop at the X-ray beam. For example, bones, they absorb X-rays and they appear on X-ray as shadows. The black or radiolucent shadows, radiolucent areas, represent areas where the X-ray beam has passed through the object and has not been stopped at all. For example, lungs appear on X-ray film as dark points, as translucents, and the gray shadows represent areas where the X-ray beam has been stopped to a varying degree. For example, different types of soft tissue such as muscle and fat. Okay. The final shadow density of any object is thus affected by the specific type of material of which the object is made. For example, high density structures appear on X-ray film as high intensity shadow because they consist of elements with higher atomic number. The thickness or density of the material, the shape of the object, the intensity of the X-ray beam used, the position of the object in relation to the X-ray film, and the sensitivity of the film. Okay. An exposed film is white, as you can see here. During interaction, X-rays with X-ray film, fully exposed film turns black because X-rays cause chemical reaction when it reaches the film. Therefore, body parts which directly reflect X-rays, for example lungs, are seen as black in X-ray film. But something in the way makes a shadow, for example, the organs which partially reflects X-rays, for example bones, fat, are seen as gray or its different shades. And these areas are called shadows on X-ray. That is, high density structures in our body, for example, bones, calcified structures, and metallic foreign bodies, they appear as shadows, but air and, for example, lung, they appear as translucent. That is, in radiology, in radiography, we have two types of intensity, translucence and shadows. Okay. Different structures of tooth appears on X-ray film also as translucents or shadows. After a while, I will give detailed information about it. Okay. The position of the X-ray beam, object and film needs to satisfy certain basic geometrical requirements. These include the object and the film should be contact or as close together as possible. The object and the film should be parallel to one another. The X-ray tube head should be positioned so that the beams meets both the object and the film at right angles. First picture, it is correct picture because film and object parallel and in contact, as you can see here, and parallel X-ray beam meeting both the object and film at right angles. But in other picture, they are incorrect picture. There's image elongated picture and image foreshortened picture, and object position is not ideal. The ideal X-ray beam used for imaging should be sufficiently penetrating to pass through the patient and reach with the film emulsion and produce good contrast between the different shadows, and parallel, non-diverging to prevent magnification the image. The apparent density of a particular radiographic shadow can be affected considerably by the density of the surrounding shadows. In other words, the contrast between adjacent structures can alter the perceived density of one or both of them. This is of particular importance in dentistry, where metallic restorations produce densely white radio-opaque shadows that can affect the apparent density of the adjacent tooth tissue. Okay. You know that in radiology we use from different types of rays, ionizing and non-ionizing rays, and you know that exposure to ionizing radiation causes damage to living tissue and can result in radiation burns, cell damage, radiation sickness, cancer, and death. Ionizing radiation has sufficient energy to affect the atoms in living cells and thereby damage their genetic material, DNA system. And the cells in our bodies are extremely efficient at repairing this damage. Because during investigation we must use from different protective measures from damage action of ionizing rays. They are: no practice shall be adopted unless its introduction produce positive net benefit. This principle we name justification. All exposure or exposures shall be kept as low as reasonable and practicable. We name this principle ALARA, taking economic and social factors into account, optimization, and the dose equivalent to individuals shall not exceed the limits recommended by Internal Commission on Radiological Protection. We name it limitation. Ionizing radiation is a subject of considerable safety legislation designed to minimize the risk to radiation workers and to the patient, and the Internal Commission on Radiological Protection regularly publishes data and general recommendations based on different principles, as you can see here in this picture. Okay. And radiographic safety and quality assurance depends on three main factors: manufacturer's responsibility, dentist responsibility, and patient's responsibility. Okay, now I will say about radiography, dental radiographic image. One of them is intraoral radiographic view. Dental radiographic film is supplied in various sizes and degrees of sensitivity, each designed for a specific purpose. Film should be stored in a cool, dry place free from chemical contamination. High temperatures and different chemical elements will cause deterioration of the film's emulsion. Okay. Intraoral radiography. Why we name it intraoral radiography? Because in this type of radiography, radiographic film, or the doctor, is exposed inside the patient's mouth, because we name it intraoral radiography. And in this picture we can see image of a small area, a few teeth and adjacent supporting structures. In this picture you can see dental X-ray tube head, which is used in intraoral radiography. Okay, thus placing the radiographic film or sensor inside the mouth produce an intraoral radiographic view. Most dental radiographs are made on intraoral film. An intraoral radiograph is made with the film held in the mouth during exposure. Intraoral radiographs taken in closer relation to the object give more detail than is possible with extraoral radiographs, which are taken from outside the mouth and have less superimposition of shadows. In practice, we have 4 types of intraoral radiography: periapical view, bite-wing view, occlusal view, and full mouth series. Okay, first type of intraoral radiography is periapical radiography. Periapical radiographs depict the crowns and roots of between 2 and 4 adjacent teeth, together with their supporting alveolar bone. They are therefore used for the diagnosis of periodontal bone loss and periapical pathology. There had been a long-standing requirement for dental students which would help them to understand the basic techniques for intraoral periapical radiographs. Intraoral periapical radiography is an adjunct to the clinical examination and provides useful information about the different components. The periapical view shows the entire crown and root of the tooth, which provides vital information to aid in the diagnosis of the most common dental disease. Okay, main indications to periapical periapical radiography are detection of apical infection or inflammation, dental trauma, assessment of root morphology, endodontic diagnosis, planning, treatment, and monitoring. This picture you can see periapical view, and you can see from 1 to 3 complete tooth and the surrounding periodontal ligament and alveolar bone. Next type of intraoral radiography is bite-wing view. The bite-wing radiography is a commonly used intraoral imaging technique in oral and maxillofacial radiology. The creation of ideal and diagnostic image is challenging and depends on good technique. The bite-wing radiograph is an image that depicts the maxillary and mandibular crowns of the tooth, providing a clear image of the interproximal surface of the tooth and allowing for detection of interproximal caries. The maxillary and mandibular alveolar crest are imaged, permitting the evaluation of their levels, contributing to the assessment of periodontal status. Additional important findings may be detected on bite-wing views, including the condition of restorations and the presence of calculus. Okay. So important indications of bite-wing view are basal examination, detection of dental caries, non-carious tooth loss, monitoring the progress of any loss of tooth, investigation of tooth structure and restorations, and assessment of periodontal status. During investigation, bite taps or a film sensor holding device, as you can see here, may be used to hold the film sensor in the patient's mouth. Bite tabs are available in folding types, stick-on types, and manufacturer-applied tabs. And this instrument has the advantage of an aiming ring and rod to hold position, the X-ray machine position indicating device. The bite block on this kind of device is thicker and keeps the patient's tooth further apart, thereby limiting the anatomic coverage of the image. Also, the position of the aiming ring limits the justomization of the beam angulation for the patient's anatomy. Okay. Next type of intraoral radiography is occlusal view. Occlusal radiography is defined as those intraoral radiographic techniques taken using a dental X-ray set where the image receptor film, X-ray film, is placed in the occlusal plane, as you can see here. Occlusal X-rays show the root or floor of the mouth and are used to find extra tooth that have not yet broken through the gums, jaw fractures, a cleft palate, cysts, abscess, or growth. Occlusal X-rays may also be used to find a foreign object. Thus, occlusal radiographs cover a large area than the periapical radiograph and are typically used in orthodontic diagnosis of the anterior maxillary tooth. Important indications are: locate what retained roots, supernumerary tooth, and erupted of impacted tooth, foreign bodies in the maxilla, mandible, salivary gland calcifications, stones, locate and evaluate the extents of lesions, evaluate what boundaries of the maxillary sinus, fractures of maxilla or mandible, patients who are unable to open their mouth more than a few millimeter, area of cleft palate, and measure change in the shape and size of maxilla or mandible. In this picture you can see periapical view, taking of periapical view of patient. First picture, periapical assessment of upper anteriors, detection of impacted tooth, odontogenic tumors, localized impacted tooth, evaluate the size and extent of cyst, and assessment of fractures of anterior tooth. But second picture is lateral oblique occlusal view, as you can see here. This view indications, main indications are periapical assessment of maxillary posterior tooth, evaluation of size and extent of lesions, assessment of condition of floor of maxillary sinus, determine the position of roots displaced into the antrum, and assessment of fracture of posterior tooth. And finally, full mouth series. As you can see here, full mouth series consists of 4 bite wing view, 2 malar bite wing, left and right, and 2 premalar bite wings, 8 posterior periapicals, 2 maxillary malar periapicals, 2 maxillary premalar periapicals, 2 mandibular malar periapicals and premalar periapicals, and 6 anterior periapical view. Remember that we have 4 types of intraoral radiography: periapical view, bite wing view, occlusal view, and full mouth series. Next type of radiography in dental practice is extraoral radiography. Extraoral radiography, and different types of them, is placing the radiographic film or sensor outside the oral cavity on the opposite side of the head from the X-ray source. Okay, and that's in these methods, radiographic film and detector is placed outside of the patient mass, and this method can image large areas of the mandible and maxilla, face and skull. Okay. They have different types of extraoral radiography. Also, they are panoramic radiography, maxillofacial techniques, TMG view, temporomandibular joints, and maxillary sinus views. Okay, first of them is panoramic radiography, or we name it panoramic X-ray. Is a two-dimensional dental X-ray examination that captures the entire mass in a single image, including the tooth, upper and lower jaws, surrounding structures and tissues. The jaw is a curved structure similar to that of a horseshoe. A panoramic film able to show a greater field of view, including the heads and necks of the mandibular condyles, the crinoid processes of the mandible, as well as the nasal antrum and the maxillary sinus. In this picture, you can see digital panoramic radiography, and panoramic radiography is a radiologic technique that provides an overview of the jaws and surrounding structures, as you can see here. It's frequently indicated when professionals want to evaluate some structures such as an erupted third molars, orthodontic treatment, tooth development, developmental abnormalities, trauma, large lesions, and other. The panoramic radiograph allows the dental professional to view a large area of the maxilla and mandible on a single film. In this digital panoramic radiography, you can see bifid mandibular canal image on the left side. They are seen so clearly. Okay. Panoramic radiography has many advantages, including short time for the procedure, greater patient acceptance and cooperation, overall coverage of the dental edges and associated structures. More anatomic structures can be viewed on a panoramic film than a complex intraoral radiograph series. The panoramic radiograph is less confusing to the patient than a series of small separate intraoral radiographs. It's one of important advantages of this method, making it easier for the dentist to explain the diagnosis and treatment plan to the patient. Also, the panoramic radiograph is an excellent imaging modality in patients with trauma, because such patients can't open their mouth and this is not needed to take a panoramic film. It's an excellent projection of diverse structures on a single film, which no other imaging system can achieve. Individual structures may be imaged by other methods once pathologic conditions have been detected using the panoramic radiography. In this picture, this is a digital panoramic radiography with a calcified stelloid complex on both sides, as you can see here. They are seen so clearly. On the right side, we can observe the stelloid ligament calcification near the hyoid bone. On the left side, a fragmented stelloid ligament calcification can be seen. Okay. And nevertheless, this radiographic examination present a lack of details and resolution of some structures due to overlapping anatomical structures in the image, mild distortion and magnification. That's important. Disadvantages of panoramic radiography is overlapping of anatomical structures in the image and mild distortion and magnification, as you can see here. Objects of interest that are located outside the focal through. It's the area of the dental anatomy that is reproduced distinctly on the panoramic radiography are not seen, and artifacts are common and may easily be misinterpreted. These features limit the indications of panoramic radiography in cases where details and accurate measurements are needed. In practice, we use from different maxillofacial projections also. They are standard occipitamental position, 30-degree occipitamental position, posterior anterior of the skull, posterior anterior of the jaws, reverse down position, rotated posterior anterior position, true lateral skull, submental vertex, transcranial and transpharyngeal positions. Okay. In this picture, you can see investigation of the maxillary antra and detecting the different fractures. This standard occipitamental view. This method is used for diagnosis of different fractures, such as Lefort fractures, nasoethmoidal complex, orbital blowout, coronoid process fractures. Also, with help this method, we can investigate of the frontal and ethmoidal sinus also. Investigation of sphenoidal sinus. Sphenoidal sinus in normally paranasal sinus appears as translucent, as you can see here. This maxillary sinus, frontal sinuses, and ethmoidal sinus. Okay. This posterior anterior view and principle of taking of this view, with help this method we can investigate fractures of the skull. Also we can investigate frontal sinus, conditions affecting the cranium, particularly Paget disease, multiple myeloma, hyperparathyroidism, and intracranial calcification. Okay. This is posterior anterior position of the jaw, of mandible. This projection shows the posterior parts of mandible. It's not suitable for showing the facial skeleton because of superimposition of the base of the skull and the nasal bones. Main indications are fractures of the mandible, especially posterior third of the body, angles, and candular necks, lesions such as cysts or tumors in the posterior third of the body or ramming of mandible, mandibular hypoplasia or hyperplasia, and maxillofacial deformities. Okay, in this picture you can see reverse down view, and this projection shows the condylar head and necks. The original Tans view in AP position was designed to show the occipital region, but also shows the condyles also. However, since all skull views used in dentistry are taken conventionally in the PA direction, the reverse Tans and PA projection is used. Main indications of this view, of this position, are high fractures of the condylar neck, intracapsular fractures of the temporomandibular joint, investigation of the quality of the articular surface of the condylar heads in temporomandibular disorders, and condylar hypoplasia or hyperplasia. Okay. This lateral skull position, lateral skull view, this projection shows the skull wall and facial skeleton from the lateral aspect. The main difference between the true lateral skull and true cephalometric lateral skull taken on the cephalostate is that the true lateral skull is not standard method. This view is used when a single lateral view of the skull is required, but not in orthodontics or growth studies. Main indications are fractures of the cranium and cranial base, middle third facial fractures, to show possible downward and backward displacement of the maxilla, investigation of the frontal, sphenoidal and maxillary sinuses, conditions affecting the skull wall, particularly Paget disease, multiple myeloma, hyperparathyroidism, conditions affecting the sella turcica, such as tumor of the pituitary gland in acromegaly. Okay. This picture you can also see posterior lateral oblique and anterior posterior view of patient. Okay. As a type of extraoral radiography is submental vertex view. This position shows the base of the skull, sphenoidal sinus and facial skeleton from below. Main indications are distractive and expansive lesions affecting the palate and base of skull, investigation of the sphenoidal sinus, assessment of the thickness of the posterior part of the mandible, fracture of the zygomatic edges to show in bones the submental vertex view taken with reduced exposure factors. Its advantage of this method. Okay, TMG, temporomandibular joint view. The axial-lateral temporomandibular joint view allows for visualization of the articular tubercle, mandibular condyle and fossa, and thus useful to identify structural changes and displaced fractures, as well as axis excursion and joint spaces. Clinical indications include trauma, the presence of joint noises, and occlusal alterations. Okay. In dental practice, we also used from different types of digital imaging, and advantages of them are no use of films, intensifying screens and cassettes. Computer hardware and software allows us to view and store images. Multiple images are obtained without changing film holder or using new film, and so important is less exposure to radiation. One of this method is radiovisiography. This method is rapid, low-dose digital imaging system using a small intraoral sensor instead of radiographic film, an intensifying screen, and a charge-coupled device. It presents the possibility of reduced patient exposure and minimal distortion, although resolution and latitude are inferior to standard dental radiography. A receiver is placed in the mouth, routing signals to a computer, which images the signals on a screen or in print. It includes digitizing from X-ray film or any other detector. Okay. Next method is computer tomography, CAT scan. You know that with help CAT scan we can receive image of different layers because we name it tomography. There is increasing use of computer tomography in dentistry, particularly to plan dental implants. There may be significant levels of radiation and potential risk. Spatial designed CAT scans, CBCT cone beam computer tomography scanners, can be used instead, which produce adequate imaging with a tenfold reduction in radiation. Okay, and main advantages of this method in dental radiology are radiographic cutting of a region structure into thin slices, good diagnostic information, and in maxillofacial surgery for diagnosis and treatment, treatment planning of tumors, fractures, and different neuropathies. But you know that in this method, dose of radiation is high. Okay. In this picture, you can see computer tomography in different layers, a computer tomography of skull on different layers, and three-dimensional reconstruction. And so important method on maxillofacial region is cone beam CT. Cone beam CT is a variation of traditional computer tomography system. These systems used by dental professionals rotate around the patient, capturing data using a cone-shaped X-ray beam. These data are used to reconstruct a three-dimensional image of the following regions of the patient's anatomy, such as dental region, oral and maxillofacial region, including mouth, jaw, and neck, and ears, nose, and throat. These systems have been sold in the different countries since in the early 2000s and are increasingly used by radiologists and dental professionals for different clinical applications, including dental implant planning, visualization of abnormal tooth, evaluation of the jaws and face, cleft palate assessment, diagnosis of dental caries, endodontic diagnosis, and diagnosis of dental trauma. These all are main indications of cone beam computed tomography. Okay. Magnetic resonance imaging for investigation of maxillofacial region gives better soft tissue image than computer tomography. That's for investigation of soft tissue disease. We use from magnetic resonance tomography very good, we can receive very good diagnostic information, and for diagnosis and treatment planning of tumors, fractures, and neuropathies, we can use this method. Also, this method is good gold standard method for temporomandibular imaging, and you know that this method is no radiation method. It is a main advantage of magnetic resonance tomography. In this picture you can see MRI of the mandible. As you can see here, you can see pathologic lesion. The lesion is slightly hypointense to muscle on T1 mode and heterogeneously hypointense on T2 with foci of low. And you can see enhancement is seen after contrast administration. Okay, and next method is ultrasound. Ultrasound limited use for dental care. Usually in maxillofacial region we use ultrasound for salivary gland tumors, sometimes for diagnosis of temporomandibular joint, and for diagnosis of foreign object in soft tissue and soft tissue cysts. Okay, in this picture you can see providing of ultrasound and different ultrasound image on B mode. Okay, contrast studies. This investigation use contrast media, radio-opaque substances that have been developed to alter artificially the density of different parts of the patient. Thus, by altering the patient, certain organs, structures, and tissues invisible using conventional means, can be seen. Main contrast studies used in the head and neck include cellography, contrast investigation of salivary glands, arthrography, contrasting of joints, temporomandibular joint in maxillofacial area, computer tomography, sometimes in this method we use from contrast agent, especially for diagnosis of tumors to provide general enhancement, and angiography. This involves the introduction of iodine-based contrast agent into selected blood vessels in the head and neck region. This involves usually the carotids, sometimes internal or external carotid artery, or the vertebral arteries. Okay. Cellography is a contrast investigation of salivary gland. Ideally, contrast media should have no harmful effects at all. However, there is a small risk associated with their use, especially with the iodine-based solutions when they are introduced into the bloodstream. Cellography can be defined as a radiographic demonstration of the major salivary glands by introducing a radio-opaque contrast medium into the ductal system. The procedure is divided into three phases: the preoperative phase, the filling phase, and the emptying phase. Preoperative phase involves taking preoperative radiographs, if not already taken before the introduction of the contrast medium, for the following regions: to note the position and or presence of any radio-opaque abstraction, to assess the position of shadows cast by a normal anatomic structure that may overlie the gland, such as the hyoid bone, and to assess the exposure factors. In filling phase, obtain the scanned films. The relevant duct orifice needs to be found, probed and dilated, and then cannulated. The contrast medium can then be introduced. The main techniques are available for introducing the contrast medium. When this is complete, the filling phase radiographs are taken, ideally at least two different views at right angles to one another. And finally, in emptying phase, the cannula is removed and the patient allowed to rinse out. The use of lemon juice at this stage to aid excretion of the contrast medium is often advocated, but is seldom necessary. Okay. Main indications to cellography are to determine the presence and or position of calculi or other blockages, whatever their radio density, to access the extent of ductal and glandular distraction secondary to an abstraction, and to determine the extent of glandular breakdown and a cried assessment of function in cases of dry mass. At the end, I want to summarize radiologic imaging. The goal of dental care is to preserve and improve patients' oral health while minimizing other health-related risks, and the decision to conduct a radiographic examination is based on the individual characteristic of the patient. These include age, general health, clinical findings, and dental history. At the first patient visit, it is necessary to obtain the patient's medical and dental history. After the recording of this information, the patient is clinically examined. This examination may disclose dental problems that will prove crucial to decisions relevant to the radiographic examination. Radiographic examination is necessary when the history and clinical examination have not provided enough information to evaluate completely a patient's conditions and formulate an appropriate treatment plan. Radiographic exposures are necessary only when the patient will potentially benefit by the discovery of clinically useful information on the radiograph. As you know, in dental radiology, we can use from different types of radiographic imaging and modern diagnostic imaging such as computer tomography, magnetic resonance tomography, especially cone beam computer tomography. With the introduction of new and advanced imaging techniques as computer tomography scanning or magnetic resonance imaging and different digital imaging, the field of dental radiology has greatly expanded. The new techniques can be used by dental professionals to analyze dental images in ways that were before unobtainable. For example, the use of computer tomographic scans for diagnosing lesions and planning implant cases, and the use of magnetic resonance tomography to visualize soft tissues of temporomandibular joint and evaluate pathologic components are now accepted as standard procedures in dental radiology. Also, with help of these methods, we can diagnose malignant tumors of maxillofacial area in early stages. Volumetric computer tomography is the newest method of analyzing and discussing with the patient treatment plan a priori using dental implants, and it makes possible to check the results. I want to talk briefly about benefits of digital dental x-rays because these methods are so important in dental practice. For example, less radiation. Digital dental x-rays have the ability to take multiple intraoral x-rays in minimal time with far less radiation exposure than conventional radiography. And the next benefit of these digital dental images is more accuracy with improved image quality. Using this advanced technology, we take an X-ray of oral cavity using a small sensor which records the image of tooth and sends into computer. And the computer then broadcasts a highly detailed image of oral cavity that can be enhanced, enlarged, sharpened, colorized, or displayed as a negative to more effectively diagnose dental conditions and determine the treatment of patient. The software used to manage X-rays can enhance the image, and also these capabilities are impossible with conventional X-rays. Okay, one of advantages of dental image is digital storage and progress tracking. Digital X-rays also come with the added advantage of being able to be easily achieved in patient's digital file to be reviewed instantly at any given time. X-rays can be superimposed with images taken earlier, so patient can visually see the progress change during treatment. With this powerful technology, patient can visually see changes related to tooth movement, bone loss or growth or restoration, and other factors. The first step in image analysis is to use a systemic approach to identify all the normal anatomy present in an image. A profound knowledge of the variation of normal appearance is required to be able to recognize an abnormal situation. The best learning method is to identify normal anatomy in every radiograph analyzed. If the images are of poor quality, it might be prudent to obtain better quality images before proceeding to the analysis. Okay, so we have talked about dental diagnostic imaging and have already been aware of the fact that these methods are specific. Each of them has their own application field. It's important to note that firstly physical clinical treatments should be conducted to patient, and then dental radiological treatments should be chosen. Thus we must provide radiological imaging just after clinical examination of patient. Now I will be talking about some points of radiological anatomy of tooth, dental radiographic anatomy. You already know that in dental practice we can use from different types of radiographic methods, and in all methods we can see two types intensity: shadow and translucence. High density structures appear as white points or gray areas. We name it shadow, but lower density structures appear as dark points. We name it translucence. And on radiography, the thicker, more mineralized or denser tissue, the more shadow it will appear in the image, but less dense thinner tissue appears as translucent or transparent. Strictly speaking, the terms radiolucent, dark black, and radio-opaque, light white, are used in plain radiographic image. That shadow or radio-opaque or white areas and translucent or radiolucent, dark or black points on radiograph. Okay, and tooth appear on X-ray film also as shadow and translucence depending on density of structure. Enamel, dentin, alveolar bone, and lamina dura appear as shadow, radio-opaque areas, but pulp space and periodontal ligament space appear as translucence because they are soft tissue. Okay, in this picture you can see tooth X-ray anatomy. As you can see here, enamel, dentin, cementum, they appear as shadow, as high because the density is high, but pulp cavity, lamina dura appear as translucent, as dark areas, dark points. In this picture you can see X-ray anatomy of tooth. Pulp cavity appears as translucent. Higher density structures appear as shadow. Restoration materials with higher density also appear as high intensity shadow. Okay. Supporting structure are lamina dura, alveolar crest, periodontal ligament space, and cancellous bone. First of them is lamina dura. Look carefully, please. Lamina dura is thin radio-opaque shadow bounding the sound tooth socket, appear as translucent. Alveolar crest is radio opaque line between tooth, gingival margin of the alveolar process, cortical border of the alveolar bone, mercable resorption with periodontal disease. In normally, they appears as a sharp angle continuing with lamina dua, but during periodontal disease, this angle is rounding. This rounding angle indicative of periodontal disease. And periodontal ligament space. Periodontal ligament space, it is a radiolucent space between tooth root and lamina dua, and the space is occupied by periodontal ligament. Okay, and remember that these guidelines are important for diagnosis of dental disease. Today we discussed about dental radiology, about different dental imaging, and important key points of normal dental radiographic anatomy. In the next lecture we will talk about radiology of dental disease, but today I presented you the latest intra and extraoral radiographic techniques used in dental practice. Because of the increasing complexity of diagnostic tasks and imaging techniques, interaction among dentists, oral radiologists, head and neck specialists, but also general radiologists is becoming more important, not only for adequate diagnosis, but also for selection of the proper imaging technique by any of those disciplines. Thank you for your attention.